All right, today we're tackling a condition that can be, well, seriously scary, pericarditis. We're going to get into what it is, how doctors nail the diagnosis, and what the latest treatments look like. So let's jump right in.
So, picture this. You get a sudden, sharp, stabbing pain right in your chest. Your mind immediately goes to the worst-case scenario, right? A heart attack. But what if it's something else? This exact situation happens all the time in emergency rooms, and it turns out about 5% of all those ER visits for chest pain that isn't a heart attack is actually due to pericarditis. So, what on earth is it?
To really get a handle on that pain, we first have to understand a little bit about the heart itself. We're going to look at its protective layer and see what happens when it gets angry and inflamed.
Okay, so your heart doesn't just float around in your chest. It's actually tucked inside this thin, two-layered sac called the pericardium. The best way to think of it is as a personal bodyguard for your heart. It's tough, it's protective, and in between its layers is a tiny bit of fluid. This fluid acts like a lubricant, letting your heart beat millions of times without any friction. Pericarditis is, pretty simply, when that bodyguard, that protective sac, gets inflamed and really irritated.
And we're not talking about some obscure one-in-a-million condition here. Pericarditis is actually the most common disease that affects the pericardium. That 5% number we mentioned, it really just drives home how often this is the culprit when people rush to the ER terrified they're having a heart attack.
So, when someone shows up with that classic, sharp pain, how do doctors figure out if it's pericarditis? Well, it's kind of like solving a puzzle, and they have a really clear checklist to follow.
The very latest guidance from 2025 boils it all down to two main steps. Now, step one is non-negotiable. You've got to have that specific kind of chest pain. It's sharp, it gets worse when you take a deep breath in, that's what pleuritic means, and this is the classic giveaway, it actually feels better if you sit up and lean forward. If that box is ticked, then the doctor moves on to step two, hunting for more clues.
And these clues can come from all over. Sometimes a doctor can actually hear a friction rub with a stethoscope. It's this weird, scratchy sound of those inflamed layers rubbing together. An ECG is also key because it shows specific electrical patterns that scream pericarditis, not a heart attack. Then you've got blood tests looking for signs of inflammation, like a high C-reactive protein or CRP. And of course, modern imaging can spot fluid building up around the heart or even see the inflammation itself.
What's really neat is how these clues all add up to build a case. If you have the classic pain, plus just one other clue, the diagnosis is possible pericarditis. But if you have that pain, plus two or more of those other clues, boom! That's a definite diagnosis. It's a super logical way to go from suspicion to certainty.
Okay, once the diagnosis is pretty clear, the next question is a big one. Just how serious is this particular case? Is this something that can be managed at home, or does this person need to be in the hospital?
This is where doctors start looking for red flags. They have a list of what they call predictors to help them decide. The major predictors are the really big warning signs, things like a high fever, a whole lot of fluid around the heart, or not getting better after a week of standard treatment. The minor ones, like being on blood thinners, for example, are also really important clues that might tip the scales toward admitting someone for closer observation.
But here is some fantastic news, and it's so important. For the vast majority of cases, the ones that are caused by a virus or where the cause is just unknown, which doctors call idiopathic, the long-term outlook is actually really good. It's a scary experience, for sure, but most people recover fully.
So, how do we fix it? The modern treatment playbook has some pretty clear goals. Get that inflammation down, get rid of the pain, and, crucially, stop it from ever coming back. The standard first-line treatment is a 1-2 punch. First, you hit it with a high-dose anti-inflammatory medicine like aspirin or ibuprofen to fight that fire and relieve the pain. At the same time, you add a second medication called colchicine. This one is the secret weapon for preventing it from coming back. And there's one more piece that is absolutely non-negotiable: rest. Seriously, restricting exercise is critical until everything has calmed down. Now, that combination works for most people. But what if it doesn't? What happens if the case is just plain stubborn and the symptoms just won't go away?
This is where treatment has seen a huge leap forward. For these tough, inflammatory cases, we now have these incredibly targeted therapies called anti-IL-1 agents. Drugs like rilonacept are amazing. They go in and block one specific molecule, interleukin-1, which is a major troublemaker driving the inflammation. Corticosteroids are also an option, but doctors try to be careful with them because they come with more side effects.
So why are these new drugs such a game changer? Well, it's because they are perfectly matched to the disease itself. It turns out that a huge chunk of cases, we're talking 80 to 90%, are the inflammatory type. These are the patients with that high CRP level in their blood. Since these anti-IL-1 drugs go straight for the source of that inflammation, they are an incredibly powerful and precise tool for the majority of people with this condition.
Probably the biggest worry for anyone who's gone through this once is the thought of it happening again. So let's talk about recurrence, because it's a real thing.
And that fear, it's completely justified. If you don't use the right preventative therapy from the get-go, the numbers are pretty sobering. Somewhere between 15 and 30% of people will have it come back. That's a big risk, and it's why preventing it is so important.
So why does it return?
Well, for most people, it's not a new virus or a new infection. It's actually thought to be the body's own immune system just overreacting. Something triggers it, and it launches an inflammatory attack all over again. And this brings us right back to why that initial treatment is so key. Just listen to this quote directly from the major cardiology guidelines. They couldn't be clearer. Colchicine is recommended right from the start, along with the anti-inflammatories, for one specific reason: to prevent it from coming back. It's been shown to literally cut the risk of recurrence in half.
So here's the bottom line. That sharp chest pain is absolutely terrifying, there's no doubt about it. But pericarditis isn't some medical mystery. It is a well-understood condition, and for most people, it is very manageable. There's a clear, science-backed path for diagnosing it, treating it, and getting back to normal.
And that leaves us with a really hopeful final thought. With these incredible new therapies that can go in and shut down the inflammation right at its source, you have to wonder, are we getting close to a future where stubborn, recurrent pericarditis just isn't a thing anymore? It's an exciting question, and it's right at the cutting edge of what's happening in medicine today. Thanks for joining this explainer.